I'd like to invite our colleague, Dr. Valderra bano, who's the Chief of Electrophysiology Division here at Houston Methodist Hospital. He will talk about ablation and when do we refer. There you
go. All right, so we're going to be discussing when to refer patients for ablation of atrial fibrillation. Let me see. And the idea here is that we have a therapy, a procedure that can be used to get rid of atrial fibrillation. So imagine we could, so everything Dr. Kashani just talked about would be meaningless if we could really cure atrial fibrillation. So it just tells you how, from the very beginning, we're not there. But it's a very noble pursuit to try to get rid of atrial fibrillation. So in order to come up with any therapy for any disease, you need to understand the disease, right? And what is atrial fibrillation? Well, it's been described as disorganized atrial electrical activity. When you see it on the EKG, it's obvious. You have irregular QRSs, which are a reflection of the irregular and rapid activity of the atria. Mapping studies have shown, in some cases, that rapid beats originating from the pulmonary veins can lead to atrial fibrillation. So in this schematic, you see how these yellow waves arise from this vein, and as they spread throughout the atrial tissue, it breaks down into chaotic irregular activations. Some of this was verified back in the late 1990s by a French group where they took patients with AFib, they put them in the cath lab, and they put catheters in different areas of the atria, induced AFib, then shocked the patients back into normal rhythm, and then waited for AFib to come back, spontaneous AFib. And they found that in the vast majority of the patients, the first beat of AFib came from one of the pulmonary veins. So they said, it's great, let's just get rid of that. We'll see how it's not that simple, but that is the basis of the procedure that we have. A few words about atrial fibrillation. It's not just symptoms, but also it's associated with an increased risk of stroke and increased mortality. This is taken from several epidemiological studies that show that. It's also increasingly recognized as a cause of dementia, not just vascular dementia from strokes, but also it's not specifically associated with dementia, including Alzheimer's, for reasons we don't quite understand. And AFib is here to stay. These are the projections of the prevalence of non-paroxysmal atrial fibrillation. With the aging of the population, we're going to be expecting more and more patients with AFib. We have a few definitions that is important to go over when we talk about AFib. Paroxysmal AFib is that stops spontaneously and never lasts more than 7 days. Persistent is one that lasts more than 7 days. Long-standing persistent is defined as that AFib that is continuously present for more than a year. Okay, so you've been in AFib continuously all the time. Permanent AFib, permanent is not a qualifier of the atrial fibrillation. What indicates is a decision from the patient and the physician that we're not going to treat atrial fibrillation. We're not going to fight against atrial fibrillation. We're not going to try to restore normal rhythm. We leave the patient in atrial fibrillation. But there's nothing specific about that AFib other than that the patient and the doctor decide not to treat it. When you approach a patient with atrial fibrillation, we have 3 goals. Number 1, symptom suppression. We need to make the patient feel better. And number 2, improve outcomes. How do we improve outcomes? 2 goals, I said, not 3. We need to prevent strokes. We need to prevent tachycardia-induced myopathy. Patients that have atrial fibrillation and a poor control of the ventricular response will go on to develop tachycardia-induced cardiomyopathy, which can lead to heart failure and a serious disease with much more serious implications. Ideally, we would like to reduce dementia and reduce mortality associated with atrial fibrillation. So how do we control the rhythm? How do we restore normal rhythm? Drugs, so AAD means drugs, antiarrhythmic drugs. Drugs are really pathetic. When you take Tylenol, the fever goes away. When you take an antibiotic, unless you're treating the wrong antibiotic, it usually takes care of the infection. When you treat someone with antiarrhythmics, it's the same thing as tossing a coin. You don't know if it's going to work. Efficacies for antiarrhythmic drugs are around 50%. And they don't really get rid of atrial fibrillation, even when they work. They just delay the recurrence of atrial fibrillation. So if you have someone that has AFib and has episodes every other week, you give them an antiarrhythmic and they may have it every other month, but they will still have AFib. You do not get rid of atrial fibrillation. Plus, the choice of antiarrhythmic drugs is very, very critical. You have to individualize which drug you use for which patients, because certain drugs could kill the patient if using the wrong patient. For example, if the patient has structural heart disease and heart failure, the only drug that is safe, the only drugs that are safe is amiodarone and dofetilide. And that is because if you give any of those, flecainide, propafenone, or sotalol to these patients, you may kill them. You increase the risk of ventricular arrhythmias and sudden cardiac death. So this is a very, very delicate situation. You don't want to use drugs randomly. And when I say safe, amiodarone and dofetilide, these are drugs that when used long-term, amiodarone can kill you with lung toxicity, liver toxicity, eye toxicity, skin toxicity, and thyroid toxicity. Dofetilide, you need to stay in the hospital for 3 days just to make sure you don't die, because you need to check that it's safe. So these are the kind of drugs we're dealing with. These are dangerous drugs that on top of that don't always work. Now, the interesting thing about this chart here is that, sure, you need to individualize the choice of drugs for each patient, but for every kind of patient, catheter ablation is a viable alternative. So let's go back to ablation. Again, I mentioned at the beginning that we need to think in terms of mechanisms to have effective procedures. And I showed the pulmonary vein firing, and that's a very simple thing to understand. The truth is, it's far more complex than that. This is a cartoon describing, some of the potential mechanisms of atrial fibrillation that have been shown to have some support experimentally and perhaps clinically. The left atrium is coated with nerves that can trigger atrial fibrillation, and those may be targets to ablation. And if you get rid of those nerves, you may improve the success of ablation. There is electricity spinning in different areas of the heart, particularly concentrated in the back of the left atrium. Some people advocate to just ablate the entire posterior wall of the left atrium to get rid of areas where electricity can spin and sustain these crazy electrical waves. And most patients will have a different combination of one or the other. Okay, so either firing from the pulmonary veins like I described, the nerve activity, the rotational activity of the electrical waves. The key to understand this is that the business is in the back of the left atrium. And whether it's pulmonary vein isolation with circular lesions that we create basically burns around the pulmonary vein mouth so that we create a scar that then prevents those electrical waves from disorganizing, or simply ablating just everywhere in the back of the left atrium have been proposed. The most popular approach, the one that's most established, is pulmonary vein isolation. And how does it do? Well, compared to drugs, ablation does a good job. If you look at patients treated with either ablation versus antiarrhythmic therapy, the rate of recurrence in patients treated with catheter ablation in this case is about 20%. So 80% of them will be free from arrhythmias, from symptomatic arrhythmias up to 9 months later. Whereas if you look at the success rate in patients treated with antiarrhythmic drugs, it's in the 20% range. There have been several studies looking at ablation as the first line of therapy. So you get a patient with paroxysmal atrial fibrillation, don't waste any time with any drugs, just treat them with ablation. And these are 3 important trials in 3 important journals. And all of them consistently show that if you look at symptomatic atrial fibrillation on follow-up, ablation does better. Pulmonary vein isolation does better than antiarrhythmic drugs. Look at this. Antiarrhythmic drugs here, they're not just 20% effective like in the other slide I showed you. Here is 60% effective. In the other slide, I showed you patients that had failed previously an antiarrhythmic drug. So when you haven't tried and you try for the first time an antiarrhythmic drug, you can expect success rate in about 50, 60% of the time. If you look at actual cure, so true elimination of atrial fibrillation, not just symptoms, but true elimination of atrial fibrillation, the picture is a bit more complex. This is a study that looked at patients treated with ablation or drug therapy, and every 3 months the patient will wear a 7-day halter. So this is a very labor-intensive study. And in the halter, they quantified the burden of atrial fibrillation. And here they say they basically quantify patients that did not have any atrial fibrillation in 7 days. Kind of reverse. So instead of showing you the AFib burden, they're showing you the patients that did not have any atrial fibrillation at the beginning. If you look at the end of 2 years, the patients that were treated with ablation 77% of them had no atrial fibrillation in a 7-day Holter, and 65% of them had no atrial fibrillation in the Holter when treated with drug therapy. So it's a little bit better, but key points here, drugs may actually do the trick when you first treat a patient. And ablation does not eliminate atrial fibrillation. It just decreases it. There are patients that are going to have atrial fibrillation despite ablation. This is about the same thing. If you look at which patients had less than half had their AFib burden drop by more than half, clearly more patients with ablation did better than with drug therapy. But the point is, there are still patients that have AFib. Ablation is not universally effective. There are patients that will come back with atrial fibrillation, and that is because the mechanisms of atrial fibrillation are not well understood, and our treatment does not always take care of all the mechanisms of atrial fibrillation. Let me just take care of this. But the truth is, ablation does lead to reduced AFib recurrence. And that's universal in every clinical trial that have been shown. So in terms of just summarizing, is ablation a good tool as a first line of treatment in atrial fibrillation? Sure, you're gonna get better symptom control with ablation than with drugs. If the patient has been tried with a drug, the truth is that, is 93% versus 84% success, 87 versus 41. My point here is it's worth trying a drug. It's worth trying a drug because the ablation comes with its own risks. But if you have failed an antiarrhythmic drug, there's no point in trying another antiarrhythmic drug because the success is 81 versus 7%. Patients that have failed an antiarrhythmic drug, really, it's a disservice to them to give them another antiarrhythmic drug. So as a first line of therapy, symptom control can be achieved in a substantial fraction of patients with drug therapy. Because when we do an ablation, we pay a price. There's a risk of doing the procedure. Pericardial bleeding and tamponade, 1%. TIA strokes is actually less than 0.5, but they can happen. The most dreaded complication, atrial fistula. This is where, as we burn in the left atrium, we can actually heat up the esophagus, which is adjacent to the left atrium. And if that happens, it's a mess. The patients go home fine, everything is fine, nothing happens immediately. But if the damage to the esophagus doesn't heal, then saliva of the patient as they swallow. Saliva is full of germs, they grow in the damaged esophagus, and they can lead to a growth there that can erode the esophagus, create a fistula, communication between the left atrium and the esophagus, which leads to saliva into the bloodstream, sepsis, strokes, 50% mortality. We don't want to deal with that. What we do is we measure temperature in the esophagus, and we try to avoid ablating excessively or too powerfully close to the esophagus. For the most part, these are things that we pay attention to avoid, and in most cases we avoid, and the procedure has become a routine procedure and not necessarily a high-risk procedure. But these are things that happen with the procedure, so that's one reason why you may not want to do this as a first line of therapy. Now, do we achieve stroke prevention with ablation? The answer is we don't know yet. There's a prospective study that enrolled 2,000 patients with atrial fibrillation and randomized them to ablation versus drug therapy and follow the patients for up to 5 years and monitor them for incidence of stroke, mortality, and others. It's called the Cabana Trial, which was presented just a month ago in the Heart Rhythm Society meeting, and I'll explain in a bit what the results were. Previous observational studies had shown that there's no difference in risk of stroke in a patient that has had a successful ablation compared to a patient that never had atrial fibrillation. So let me explain that. If you ablate successfully, the risk of stroke is the same as if you never had atrial fibrillation. So that's a pretty good deal. That's a pretty good deal. That is from observational studies. This is one from Michigan in 2006. This is another one from Taiwan. The bottom line is that if you show that you get rid of atrial fibrillation with ablation, will you get rid of stroke? The problem is, does it happen all the time? And that's what the Cabana Trial looked at. Cabana Trial took 2,000 patients, like I said, and they looked at death, disabling stroke, or serious bleeding, or cardiac arrest at 5 years from ablation or drug therapy. 1,000 patients in each group. If you look at the primary endpoint, no difference. 8% in the ablation group versus 9.2 in the drug therapy group, non-significant P wave. Now, what happened here is that of the 1,000 patients that got randomized to drug therapy, 300 of them got fed up with the drug therapy and got an ablation. So it's a 30% crossover, which is huge. And of the 1,000 patients that got assigned to ablation, because they did the study in all over the world, places like China and Korea, apparently if you don't pay cash, the public health system will not do an ablation on you. So patients that got randomized to ablation, 9% of them never got the ablation. So these numbers reflect the intention to treat numbers. But if you look at the actually on treatment, the interesting thing, the on treatment analysis looks 7 versus 10.9% for all-cause mortality. So there was a 30% decrease in mortality if you get an ablation. Less death, less cardiovascular hospitalization. All the numbers actually look better after ablation. The problem is, clinical trialists and epidemiologists will pontificate about intention to treat versus on-treatment analysis. The bottom line is that it doesn't seem like we're hurting patients when we ablate them, and the stroke and the mortality may improve. So when is ablation appropriate? Very simple, when the benefits outweigh the risks. So we need to individualize. Atrial fibrillation is very heterogeneous in terms of symptoms. There are patients that may present with AFib and no symptoms, and their first symptom may be a stroke. And there are patients that feel every single run of 3-4 seconds of AFib. So the AFib burden is important to consider. It's important to consider structural heart disease because that will determine our choice of antiarrhythmic drugs. Some patients tolerate the drugs better than others. Ablation success is different. It's much better in paroxysmal than it is in persistent atrial fibrillation. And the presence of structural heart disease may complicate the procedure as well. So when do I consider appropriate to refer the patient for ablation? 3 questions I ask myself. Is there patient gain? Is the patient going to benefit out of being in normal rhythm consistently? Obviously, if you are demented in a nursing home, bedridden, and you go into atrial fibrillation and you don't realize, it's okay. We're not gonna gain anything. So you need to balance the symptoms. And some patients may not have a lot of symptoms, but they may wish to stop blood thinners. And I think the Cabana may help us in support the indication of ablation for those patients. Like you may not have symptoms, so the symptoms may not bother you, but if we get rid of your blood thinner, it would be nice. So that may be a powerful motivator. The second question I ask myself, is the procedure safe in this patient? Can the patient tolerate about 2-hour procedure under general anesthesia? Some patients may not. And also I need to worry, is the patient going to survive if I have a complication? So is it okay if I perforate this patient and I have to drain a hemopericardium? Not everybody, if you walk into a procedure, you gotta be ready to do the procedure, also deal with the potential complications. So safety is another question. And then I ask myself if there are any technical aspects of a given patient that would preclude me from doing a successful job. Some patients may have massive left atrial enlargement. Some patients may have a thrombus in there, so you don't wanna do it. But in general, if the patient is gonna gain something out of being in normal rhythm, if the procedure is safe, and there are no technical impairments to my success, I think the ablation procedure is a good deal. And I stop there. Thank you very much.